Hi, everyone, and welcome Dr. Mark Blaze. Thank you for joining us today. Today's session is a little bit different from what we have done before. It's not an educational lecture or it's not a discussion of treatment options. Instead, we're going to step back and explore something more fundamental, in my opinion, in mental health care, because we're going to look at numbers, and then we're going to look at the person behind those numbers. Then we ask a simple but very important question, that is, can structured psychometric data meaningfully reveal the human behind it, right? And that's because, as we know, most clinicians, we live in narratives. Patients tell us their story and experiences. We listen carefully to the tone, the pauses, the affect, and inconsistencies. That narrative process is deeply human and valuable, but we also know that something we don't usually say it out loud, that is, clinical judgment can be very noisy. So interviews can vary from one clinician to another, and our memory is selective, and the clinician's style is different from each other. So the real question becomes, how do we preserve the narrative depth while also improving the signal clarity? How do we reduce the noise without reducing humanity? And this is what we're going to showcase today through two patient cases. This is a case study session. Before we move to the actual cases, I would love to make sure everybody understand what you are about to see. And there's nobody better than Dr. Mark Blaze can explain this to you. So please, Dr. Blaze, as our chief assessment architect at MedLink, please share a little bit more about yourself first, and then we can have a brief introduction about our assessment and including what is P factor before we move to the cases.
And thank you, Rand, for that introduction. So, as Rand said, I have come on board as the Chief Assessment Architect for MedLink Global. I'm a clinical psychologist who has had a 40-year career in the area of psychological assessment, both in mental health, in business, in sports, and in government settings, but also in psychometrics, the science of test development and measurement. And I'm excited to be part of the MedLink team as we develop what I believe is going to be the next generation psychological assessment system, one that integrates psychological science, contemporary scientific findings, with the traditional DSM disorders and the emerging power of AI technology. Today, we're going to focus on what I think is the central or core feature of this whole process, of which we call MaiNDS. And that feature is the multidimensional transdiagnostic inventory of psychopathology. I understand that's a mouthful, but the MTIP is a multi-scaled assessment tool that combines the familiarity and the knowledge that has been obtained over the years of the DSM disorders with modern findings about the empirical foundation and structure of psychopathology. By blending these modern research findings with traditional DSM disorders, the MTIP provides an efficient, comprehensive assessment of psychopathology and allows the findings to be easily translated into clinical decision making, and allows the clinician to then individualize and optimize a patient's treatment. Today, again, like Rand said, we'll be discussing these profiles from this instrument. And this is a central component to our process, but it's not the only component. We'll also see in this talk how the AI interviewer can interact with patients to provide additional information that would be helpful in understanding them as a person. Okay, so we're going to start, and as we move forward, we're actually going to expand the slides so that they're easier for people to see, because they do have a fair amount of text in them. But we want to start here when you build a psychological instrument, you have a measurement model in mind. And what we had for this instrument and for the MaiNDS system is called the Transdiagnostic Measurement Model. It has 3 levels. It has a global severity level. It has core components of psychopathology. And below it, it has clinical syndromes. And if you are familiar with the DSM, then you see that the clinical syndromes are actually consistent with the DSM disorders that are most commonly seen in psychiatric or psychological treatments: depression, anxiety, alcohol, drug abuse, impulse control, psychosis, paranoia. These are all familiar categories. But what we've learned over the years through empirical research on the DSM conditions is that these disorders aren't individual and separate from each other, that in fact, many disorders combine together to create a dimension. And these 3 core dimensions, or domains as it's called here, are internalizing. Those are the disorders that cause emotional distress. Externalizing, those are the disorders that are related to behavioral dysregulation. And thought impairing disorders, those are the ones that are related to decreasing thought quality and causing perceptual difficulties. One of the more intriguing findings from this line of research has been what's called the P factor. The P factor, or the general factor of psychopathology, is created out of these core dimensions. The dimensions themselves are intercorrelated. So when you do a factor analysis of the underlying dimensions, you get a large single factor. Much like you do with a full-scale IQ, you get a single measure, a number that indicates the overall severity of psychiatric illness and burden that the patient brings to their treater and lives with throughout their day. So if we could move to the next slide. So I want to start with the first patient. We're going to call this patient A. Mr. A is a 38-year-old married individual who's referred for a psychological evaluation by his psychiatrist. He's new to treatment, but the referral question from the psychiatrist was, the patient presents with mild depression, interpersonal conflicts, and possible ADHD. Psychiatrist asked for differential diagnosis and treatment recommendations. Mr. A had no previous mental health treatment. When asked what his motivation was for seeing the psychiatrist, he replied, "I've been having trouble at my job and my personal life is a mess. I probably have ADHD," which is common these days. People often think all of their problems are the result of ADHD. So Mr. A took our multidimensional transdiagnostic inventory, and here's his profile.
That's a lot of numbers, Dr. Place. When you
As you can see,
yeah,
it is a lot of numbers. And what is important what I want to get across is that this is actually the representation of the person who took the test. This isn't a bunch of numbers that are independent of each other or sit in isolation. And hopefully, as I go through the profile and talk about it, you'll begin to see how this all interrelates, because people are a unity. They're what I call, when I teach, post-elemental. You can break it down into components, but the real person is the way all of these things interact. And that's what we hope to be able to get when we process a profile like this, despite the fact that there are a lot of numbers. So with all psychological tests, we begin with validity. And in our profile here, the validity and response style scores are at the top. Score of 4, val of 4, means it's a valid test. The patient was able to attend to and answer consistently the items. Now, when people take tests, most people are just honest in describing themselves, but for various reasons, people can either underreport or overreport their psychiatric symptoms. In this case, Mr. A is an underreporter. His 61 there is actually high for people who are seeking treatment. That means that the elevations throughout the test are going to be mildly depressed because he's reluctant to report or unaware of the extent of his own emotional problems. To alert treaters to this, because this style of underreporting will be present in every interaction, in interviews, in sessions. Every interaction will have an aspect of this underreporting. I spoke a little bit about the P factor, or the general factor of psychopathology. And that, again, that's one of the most intriguing and perhaps leaps of understanding that have come about from the research, most recent research into psychopathology. In the minds, that number is captured by the GPS score. That's global psychiatric severity. And in this case, a 57. Well, I'll back up for a second. We're presenting scores here as numbers. And what do these numbers reflect? It represents the standing of our patient relative to the normative sample. Our normative sample is 720 plus patients that are nationally representative of the US population. We create a mean score of 50 and then a standard deviation of 10. These are T-scores now. And we can then compare the patient standing to the average score of a non-treatment seeking individual in the United States. And so when we see the GPS score of 57, it just barely crosses the line into mild overall severity. But given the fact that this individual, patient A, is an underreporter, we can assume that that degree of severity is actually higher. There's more psychiatric burden that patient A is carrying than he's revealing to us in this profile. Once we have a sense of the severity, we move to the next level of the profile. And these are the core dimensions of psychopathology. The TED is the emotional dysregulation dimension. TBD is the behavioral dysregulation, and the TTD is the thought disorder dysregulation. And we can look at those scores and see the TBD score is in the severe range. It's a 71. So that means it's 2 standard deviations higher than the average person in the United States. That puts you at the 99th percentile. Now that we know, and that helps us locate or localize where the majority of Mr. A's difficulties are coming from. They're coming from behavioral dysregulation, difficulty with impulse control, anger control, and generally being able to anticipate the consequences of one's actions before they take those actions. We can move over now and look at the TED, because that's barely the next highest one. But we do see that depression, despite this degree of underreporting, depression is still a 58, which again moves it into the mild category. And so we can assume that there's more than just a little mild depression. One of the ways that we control our actions as individuals is we anticipate consequences, and that makes us anxious if we think it's going to be a bad outcome. That's called signal or anticipatory anxiety. It appears that in addition to having behavioral dysregulation, patient A suffers from sort of a lack of anticipatory anxiety. So what would be a break or a stop and think mechanism in his psychology is missing. So that makes it easier for him to discharge anger, act impulsively. 53, that's a grandiosity scale. And while it's in the average range, it's a little unusual that it's in the average range, given the distress that we believe the patient's under, and given the mild anxiety, mild depression that we've noted. When depression goes up, grandiosity, sense of yourself as being special, entitled, and having unique talents tends to go down. In this case, it didn't go down. So we have to wonder what's keeping that in the average range. In addition to the three core domains of psychopathology, our test, the MTIP, also has supplemental scales organized into clusters. For example, we have the cognitive cluster, the somatic cluster, the functioning cluster, and the treatment cluster. These are either transdiagnostic difficulties, like feeling your memory and attention are disrupted, which are common to a whole host of psychiatric disorders, or disorders that don't fit neatly into the three primary clusters, like in the somatic cluster, the eating, and the one above it, BDY, which is bodily distress, or the old somatization disorder. They're sort of interstitial. Some of these disorders, like body distress disorder, which used to be somatization, and eating disorders, eating concerns, do not line up exclusively with any one of the core dimensions, and rather they're kind of interstitial. They fit between dimensions. So here we've got them broken out, because while they don't contribute to the core dimensions, they're still important to cover. What catches our eye in the supplemental scales is the cognitive cluster. Consistent with the self-report, or what brought him into treatment, the patient reports having subjective experiences of poor memory, inattention, difficulty concentrating, and with the ADD scale, difficulty maintaining focus or being distracted. There doesn't seem to be anything for us to pick up on in the somatic cluster. The functioning cluster is a combination of scales which tap, the first one, RSL, taps resiliency. And that's the psychological ability to bounce back from setbacks and to maintain optimism and hope. LOP is level of personality organization, and LS is just life satisfaction. So we see that the LOP, or the level of personality organization, is a little elevated. And again, with the underreporting style, his personality difficulties probably exceed this number, which is almost 1.5 standard deviations above average. LOP score of 63, which likely underestimates the degree of personality difficulty, we begin to believe, or we begin to hypothesize, that personality dysregulation is a substantial problem for patient A. And again, right below it, life satisfaction is in red, because when you're having these kinds of difficulties and your personality is a little understructured or a little unstable, you tend not to be so happy or content or satisfied with your life. So like the grandiosity scale, this is starting to combine in a way that makes you think personality disorder with a narcissistic kind of style. Now, moving over to the treatment concerns, TX and A is treatment attitude. That's the treatment attitude scale. And his is quite elevated, 79. So what makes that concerning is that Mr. A probably has unrealistic expectations about how quick and how extensive his improvement is going to be when he enters into psychiatric care. It's a measure of attitudes towards receiving treatment and your expectations of treatment benefit. The last scale, SI is suicidal ideation, and he's right at the average. So at least at this moment, we don't have to be too concerned about self-harm or safety. So this is where I've kind of put all of that jargon together. The validity, it's a valid profile with moderate underreporting that likely minimizes the elevations of the profile, but the shape and the problems and the problem areas identified are likely to be accurate. There's mild overall severity. It's in the typical range for a treatment seeker, but the true burden is likely higher. The core dimensions of psychopathology, behavioral dysregulation is the one that stands out. There's a prominent lack of self-control, poor impulse control, hostility, and these are the kinds of individuals who inadvertently get into legal difficulty. The scales, the disorder scales that are driving it are anger and impulsivity, and they're in the severe range. This makes the area of behavioral dysregulation Mr. A's primary difficulty. As we said, the other dimensions were in the normal range, but there's a mild amount of depression and a little bit of traumatic stress, which is distress from intruding images or thoughts about a past painful experience. One of the things that will be important for treating Mr. A is understanding what produces the depression and the distress from the traumatic stress scale, because emotional distress is one of the main motivators for people to enter treatment and to stay in treatment. So it'll be key to understand what is causing or pushing his depression. And as I said, the low anxiety tells us that he has no safety or no self-control switch, and this leads to unchecked impulses and behavior. In the cognitive cluster, we saw that there were significant concerns with overall cognitive functioning and ADD. These scales are not able to tell you what the cause is or if they would actually be identified with objective tests. It's just reports of subjective cognitive difficulty. Still, these likely contribute to his periods of anger and his lack of impulse control. The functional cluster, we said, starts to get us to think that there may be a personality issue involved. And when you combine that with the grandiosity scale, it suggests sort of an understructured personality with narcissistic features. And treatment, we don't have to be immediately concerned with suicidality, but the high treatment attitude scale suggests unrealistic expectations. So the early focus in treatment is going to need to be shaping expectations and setting treatment boundaries. No one test can actually give you a diagnosis, and no test itself can diagnose anything. Those are the realms of professionals who integrate multiple sources of information and clinical judgment and other contextual factors that are not represented in the profile. But we do get some impressions. The overall impression I get is that unstable personality, self-other instability, and a narcissistic style or feature leads to aggression and impulsivity that sort of bubbles up when relational conflicts occur or he experiences setbacks or disappointments in his life, his major life roles, work or parenting or being a spouse. You would also want to rule out a mild to minor depression. You'd also be cognizant that his antagonistic style and reluctance to admit emotional problems, the underreporting, and unrealistic expectations about what treatment might do or how fast it might do it will make establishing treatment challenging, with the potential for early termination, And if he does stay in treatment, a tumultuous course, ups and downs. How would you focus the treatment? Well, I would think about ways to gain behavioral control, improving behavioral control, and enhancing interpersonal functioning. The types of interventions are cognitive behavioral therapy, DBT, which stands for dialectical behavioral therapy, which is a very effective treatment for people with. There could also be medications. You could try to treat the depression with one of the antidepressants like a SSRI. There seemed to be an awful lot of behavioral dysregulation in the profile, so maybe even a mood stabilizer might be important in this case if the antidepressant doesn't do the trick. And then anger management groups, depending on how persistent the anger is as the other treatments kind of take effect. The other thing is, despite the concerns that he has about ADD and other perceived cognitive difficulties, I would delay addressing these with further evaluations until treatment has been established in most cases. However, if there was some documented event, a head injury, a stroke, a seizure, or if his mental status had acutely changed, that means that one day he was feeling fine and didn't think he had any memory difficulties, and a day or two later he was confused, got disoriented, and felt like his brain functioning never recovered, then I would go ahead and try to explore those concurrently with instituting these treatments. Next, we'll be able to see some parts of what the AI interviewer found. So from the conversation with the AI interviewer, A reports that he's experienced mental health difficulties only very briefly since 2025, and that they were triggered by personal and professional stressors. He reports significant impulsivity affecting both work and his personal life, including frequent impulsive decisions. Anger management issues are present. The episodes of explosive and argumentative behavior are disrupting his life. He experiences intense emotions, pain, embarrassment, regret, and mood fluctuations. It's interesting. He's an underreporter, and what he's saying is, so pain and regret and embarrassment aren't typically emotions. They're more covering qualities, affective qualities. So he can't really describe primary emotions. Coping strategies, he manages stress by focusing on his family during difficult moments. I'm not sure what that means to him. He's actively engaged in counseling and medication management for depression, so that's good. Treating depression may affect some of the irritability and may aid in behavioral control. He's trying to set boundaries with his distractions, phones and other things during work. His mental health challenges have negatively impacted his family relationships, work performance, and marriage. He feels he's not reaching his full potential. So I had said earlier that it'd be important to find where his depressive symptoms come from. And this is likely where it is, where he feels failure and that he's not living up to his potential. So those are the areas, if you were a therapist, you might be able to start working with, because he sees them as problematic and they cause him distress. So in addition, if we think back to the hypothesis that he has a personality disorder or understructured personality with narcissistic tendencies, these are the kind of things that activate narcissistic injury, that he's a failure, that he's not living up to his potential. So it kind of goes together with the idea that he may have a personality difficulty with narcissistic features. He began treatment in 2025, medication for depression. He's taken melatonin and hydroxine to support sleep, but continues to experience disturbances, waking up 2 or 3 times per week due to stress and trauma. I don't know. One of the things, hydroxyzine is fine for sleep. It makes people sedated, makes them sleepy, but it also has an anti-anxiety effect. And given his lack of behavioral control, I'm not sure that's the best choice. Sleep quality is significantly influenced. He says that his sleep quality significantly influences his mood and ability to manage stress. I think I would flip that around, that his mood fluctuations impact his ability to sleep. So again, I would wonder if a mood stabilizer here, in addition to or instead of an antidepressant, might be a better choice. And again, these are the kinds of symptoms that DBT is effective in treating also.
Person or any patient finish the questionnaires, the AI interviewer will dive in a little bit more to collecting more information to make this case more detailed, because in the questionnaire, we don't ask questions like taking what medication to including the treatment history and so forth. But now we have those information because we think that might be benefit for the clinicians to understand what has been tried before, and based on the score we receive, they can make further suggestion of changing, switching, or augmenting the treatment.
Right? So when the profile is scored, the AI interviewer then can interact with the patient and talk and probe about the scores and the areas of difficulty that is impulse
augmenting the treatment.
Right? So when the profile is scored, the AI interviewer then can interact with the patient and talk and probe about the scores and the areas of difficulty that his impulsivity, his anger are causing, and what kind of treatments and what kind of coping measures he's already instituted. So beyond just getting the profile and the information about the disorders, you get it placed into the context of how he's tried to manage it and how he understands it. So it's a more thorough and individualized expression or understanding of his difficulties.
Great. Shall we move to the next case?
So patient B, Mr. B is a 29-year-old single male who is just entering treatment for interpersonal problems, excessive drug use, and has shown limited improvement over the course of 6 months. We did the MTIP evaluation, was requested to clarify his clinical status and to inform treatment planning. Again, it's sort of the same array of tests, same array of scores, and I'll just re-emphasize that the scores themselves in isolation give you some information, but the goal is to integrate as much of it as you can to get a better understanding of the person. And we start again with the validity, and we see that it's valid. He attended to the items in a consistent and meaningful way. There's no underreporting. This time, though, the overreporting scale is elevated. Now, psychiatric patients do overreport symptoms, often as a way of trying to get attention or a cry for help, or if they've been psychiatrically suffering for a long time. But here we see that he's overreporting, which means some of these elevations, which are quite high, are enhanced by the overreporting. But again, like with the other case, the shape, the ups and downs, the peaks and valleys, when you look at the global psychopathology severity, it's an 83. So that's 3 standard deviations above average. That's way past the 99th percentile. This is a substantial amount of psychiatric distress. Even if he's over-reporting by a standard deviation, it it's still extreme psychiatric distress. There's a lot of burden that he has to cope with. Moving down to the core dimensions, we see again in this case that the behavioral dysregulation is a primary concern, but thought dysregulation is also a major concern, and the emotional dysregulation scale itself is mildly elevated. So all three are now elevated, which means besides having extreme severity, there's much complexity in this case, and that is going to potentially complicate his treatment. What I'd like to do now, Rand, if you could, is go to the next slide.
Sure.
So instead of us just sitting there and looking at those numbers here, you have a sense now for the structure of the report, how it's organized, it's hierarchical, it's in dimensions. And so now let's focus sort of on how it gets integrated. So like I said, it's valid, but with symptom over-reporting. The motivation for the over-reporting is unclear. While scores are high or exaggerated, the profile pattern should still be accurate. So we should still be able to interpret this pattern, just adjusting a little bit for the severity. The global severity index is severe. And when this is up, it indicates chronic psychiatric burden, functional impairment. This is the kind of psychiatric problem that interferes with major aspects of life, probably requires long-term treatment, and treatment may need to be intense at time. You may have to change levels of care at time, increase sessions, maybe have a partial or day hospital, but you have to have a flexibility when you're treating patients with this kind of severity. At the transdiagnostic level, we saw that all three dimensions were elevated, so that heightens complexity. This case is going to have, this individual will have multiple DSM diagnoses, and this will cause or potentially cause clinical complications. As with the first case, the behavioral dysregulation is the highest of the core dimensions, although thought dysregulation is also quite high. So there's severe, this is sort of uncommon to have behavioral dysregulation and thought dysregulation both in excess of a T of 70 is uncommon. So this really highlights the complexity of this disorder. Emotional dysregulation is also evident, but the primary issues are going to be severe behavioral dyscontrol and impaired thought quality. Treatment needs, to treat this kind of case, you have to have a clear conceptualization of what it is and prioritize your treatment interventions. You have, because you can't treat all of the difficulties that he has at all at once, but you can try to think about which may be more central, which may be causing or impacting the other ones the most. So that's what I mean by prioritizing treatment targets. You have to be ready for crisis management. With this profile, you could expect to get a call from a family member or the patient himself in a crisis. There's going to need to be treatment flexibility. Should probably be a team approach. So multidisciplinary with a psychologist, a psychiatrist, and a social worker, some combination of individuals to help manage the severity. When we look down into the behavioral dysregulation column, we would have seen that drug abuse is a T-score of 100. That's so high that it really makes no sense. It loses meaning. It's just, so drug abuse is a substantial, significant concern. We'll see that the patient reports that he's using marijuana to aid in sleeping, but to get a score this high, there has to be sort of pervasive drug abuse. So that immediately jumps to the fore as a potential target. And then when we move to the thought dysregulation dimension, both the mania and the grandiosity scales are elevated above T of 70. This, again, is untypical, but when it happens, it usually indicates a manic or hypomanic state. So that would also be consistent with his sleep difficulties. Now, a hypomanic state is going to have a lot of concomitant behavioral dysregulation like we see in his profile. So for bipolar illness, treatments are usually mood stabilizers and interventions to clean up sleep hygiene, regulate your wake sleep schedule, and to add structure to your life. So treating the bipolar component may significantly improve his behavioral control, may have a positive impact on his drug use and his sleep. But it will also allow for a more accurate assessment of his behavioral dysregulation. Is it primarily tied to the manic, hypomanic state, or is it independent of that? Now, another wrinkle in this case is that the psychosis scale was a T of 83. This suggests severe perceptual and thought impairment. So, in addition to mood stabilization and behavioral control, interventions that target thought quality might be considered. But successful mood stabilization may take care of that. So you may not want to start addressing the thought quality until after you see if the mood regulation improves and the thinking improves. But still, it's a potential target for treatment. So we have drug abuse treatment, treatment for bipolar disorder, and concerns or considerations about possible thought quality impairment. Next. We go to the supplemental scales, and here we can see that, the cognitive cluster, like in the other case, he perceives cognitive difficulties. This would be quite common in somebody with an active bipolar condition or a thought impairing condition like psychosis. So you don't necessarily need to address these right away. However, cognitive difficulties are going to hinder adherence to any kind of complicated medication or treatment regime. So going to have simpler treatment instructions, probably multiple formats for giving information, verbal and written, and possibly the need for some external support to help ensure that there's a follow through with treatment. The functional cluster shows personality and stability, and here low resilience. The low resilience is concerning because it may be a risk factor for early relapse. And again, to address low resilience, you may need external structure and somehow to elicit some social support system if the person has any, family members, spouses, close friends. Here the personality issues, we'd monitor them, but because there's so much, the indication of a bipolar disorder is so strong, you'd want to wait until there was mood stabilization and better thought quality to really decide if there was a true personality component or whether that was just secondary to these other difficulties. Here again, suicide is low, but still, given what we saw in his impulsivity and mania and thought quality, concerns about self-harm, impulsive self-harm, unintended self-harm would be quite high. So safety planning would be part of the treatment, despite the fact that suicidal ideation is not prominent. Here again, we see the patient has a high score on the treatment attitude scale, which probably goes with a cry for help, in his over-reporting. So that hypothesis gets some support. But again, early interventions would be needed to set reasonable expectations and to really clarify the initial goals of treatment. Overall, this profile suggests severe, complex psychiatric condition requiring flexibility, ongoing care, poses treatment challenges, both in the beginning and over time. High likelihood of an active bipolar illness with moderate thought disruption. Treatment should focus on mood stability, thought quality, and drug abuse to provide consistency to the treatment. When there are so many severe and concerning elevations or disorders or symptom clusters, treaters are at risk for polypharmacy or chasing symptoms or going after whatever the current crisis is. But by looking at the data, we can see that focusing treatment on mood stability, thought quality, and drug abuse would give you a consistent pattern or approach to treating the patient. Certainly monitor those, as they could complicate care, but I wouldn't explore them or do much to intervene with them until after treatment had been well established. Now let's see what the AI interview was able to see. So he experiences chronic anxiety with what he calls strategic worrying, with weekly unproductive worry loops that escalate to moderate anxiety. This profile really doesn't indicate anxiety as a primary concern. There was a mild elevation on the OCD scale. Maybe there's a little bit of that, but I would assume this is related more to the bipolar disorder. Impulsivity in relationships occur every few months, often driven by the need to maintain or reshape self-image, sometimes resulting in significant consequences. Anger in situations involving perceived unfairness or feeling trapped. Again, I would see most of this as falling into the area of the effects of having a more manic or hypomanic state. Social self-consciousness, rumination about others' perceptions contribute to his ongoing anxiety. He mentions anxiety over and over again, but yet there really wasn't a lot of anxiety that was reported in the profile. So it makes me think that he's kind of mislabeling things. Nightly use of marijuana as a sleep aid and anxiety management strategies, well, that's probably not very helpful. And most likely his substance use and most likely he uses substance to a far greater extent than just to help him sleep. So that clearly is an area for concern and getting clarity. Functional impact, impulsivity has negatively affected his relationship, led to costly decisions. So he's had some errors in judgment. Anger and frustration contribute to poor occupational stability. Ruminations, anxiety, consume his mental energy and reduce his present moment engagement. Again, I think he keeps going back to saying he's anxious and ruminative. I think he's misinterpreting anger as anxiety, which happens quite a bit. I think he's probably having angry ruminations. Developmental history, parents divorce at age 3, longstanding psychological impact, persistent sense of uncertainty. So, and then emotional distress, psychiatric difficulties have been present since childhood with fluctuations over time. Here, early onset is usually consistent with high severity and chronicity. So this supports the high P factor score that we saw. Treatment, recently initiated a mood stabilizer with noticeable improvement in emotion regulation and overall stability over the last month. So this is a positive sign, an indication that mood dysregulation in terms of a bipolar quality illness is likely driving much of his difficulties. But I would still closely monitor his thinking and his drug use to be sure his drug use doesn't get out of hand, and to be sure that with this treatment, his thinking, his thought quality improves. But that's where you would make the decision, if it doesn't, to maybe add some agent that was targeting thought quality.
And I think that's 2 cases we would love to cover for today.
Well, thank you. And hopefully we've been able to show a little bit about how you can take a profile that looks flat and linear and transform it into something that has more shape and dimension and is humanized and provides, through the chaos, helps you find paths for treatment that's effective and individualized.
Yes, thank you so much, Dr. Place, and thanks so much for going through very thoroughly both cases. I believe the clinicians who are watching us will have the same feeling, and it's really a tool to help clinicians to see faster and more clear, and not. I do believe this is a very important and effective tool. If to the audience, if you're interested in learning more about MaiNDS and our assessment, or you want to even participating in the future case review, please let us know, and we look forward to continuing the conversation with you guys.
And if I could just add that while it aids, it doesn't replace clinicians.
Absolutely.
It's a clinical aid. There'll always be the person, their training, their acute ability to see in the moment what's going on will be necessary, and the human connection will be necessary, no matter what kind of advances we achieve.
We always augment clinicians and have zero intention of replacing anyone. Okay. Thank you again. We will see you next month.